Thank you, Paul, for the question. So how much are we using this data to inform policies? I think the university has been trying a lot more, and hospitals have also been trying. I've been to fora that Strathmore University organizes to engage with policymakers. I think there's an annual breakfast meeting where policymakers interact with the research. But I think the part that is weak is data and financing of research. I think it's very hard to get a local grant. I think is it Nacosti? He's now giving grants, but most of the grants are focused on clinical science. But the health system and quality of care are issues that need to be addressed more. So there needs to be more recognition on where the problems are, because if it's malaria, HIV, TB, you see a lot more funding for them by the funders or the blood transfusion system, but quality of care has still not been gotten that recognition. And to do good research, you need money. You need money to collect the data. So I think it's a call for the Ministry of Health to lobby Nacosti, ring fence some funds to do research, and even our students, can we have them doing research that matters to the questions that people want answered in the quality? So in summary, Paul, I would say we need to do more lobbying to get quality on the agenda of people who are funding research, so that the questions that have been answered. And I'm really proud that people like Professor Mary Adam have been having research days, bringing to the front the importance of research in answering some of the questions. Thank you.
Thank you so much for that. This other one, I want to throw it to Benta. One of the low-hanging fruit for us to offer care with dignity and respect, and also in taking cognizance of the patient preferences, is what we call a patient's right charter. And most of our African countries have adopted this. So how can we make the patients aware of this and our healthcare workers? Yesterday, Dr. Lydia told us that we need the patient to ask us, what if? So this tool, how can we make it more aware in terms of our patients and also the healthcare workers?
Thank you, Paul. I think that would be probably among the easy things to do, because the charter is already there. What is lacking, I think, in my view, is that although the charter is there, and I'm speaking from one who has been in private practice for a long time, there has not been that much attention given to it. It must be an organization's deliberate effort to bring to their employees what the patient charter really is about. Most of these institutions, you'll find, have their own charters that they have given and place it out there for their patients, the specific patients who come to them. But really speaking about what the national charter is about is important, so that at the institution level, the staff are aware what it says, and that can be given through regular sessions, through training. I am a beneficiary of Kenyatta National Hospital's, I think it's almost 3 times a week in-service sessions, and in those sessions there has been one run on the patient's charter. And if one listens to that, one is able to know what is there. But having said so, it's one thing to hear about it, but quite another to implement it. It really must begin from the leadership. And I keep saying this, that unless your leader, unless the heads or top management staff are aware of some of these things, and unless they have made them priority, the staff never get to hear about them. And staff will only hear about it and embrace them if they see their leaders talking about it. So town halls, training sessions, availability of that information to staff is very, very vital, so that they also know what the patient's rights are. And patients are well versed with their rights, so that if you're challenged by a patient, then you know how to respond to that right. So I think it's a little more education, Paul, a little more openness to patients' criticism, because they are not really bad. They actually, are very, very helpful in improving what you're not doing well in your service. So rather than dwell on the, and this has been my fight, rather than dwell on the compliments that the patients often send, also find out what they're unhappy about. Deliberately go out to find out what is it that we did that did not please you, so that you're able to address that angle as well. Thank you.
Thank you so much for those comments. And I want to open the floor. We can take 4 questions. So we can start from behind there. We have our colleague from Nigeria.
Good morning, everybody. I'd like to thank the 2 presenters for what they've talked about this morning. I would like to ask, because it was really quite interesting. When you went for the study, I've forgotten the name of the place where you said is an outskirt in Nairobi, Dalora. Thank you. Yeah, so if you came from the Christian point of view, if I'm not a Christian, wouldn't that be like something that could affect the study? If I'm a Muslim or I'm an atheist, and was that an overt way in which you did the study, or was it upfront, in which case that could be a bias in the study? And then in your various studies, I'm just trying to find out if health literacy was an issue, because health literacy affects patient satisfaction and of course patient experience, because, and also the rights. If I'm aware of my rights and you treat me poorly, then I'll talk. You know, I'll know that there's something wrong in the way you've treated me, because you've broken that right, so what will I say? But if I'm not even aware that I'm supposed to be treated that well, or it's my rights, then I'm not going to complain about it. So knowing my rights, knowing about health, being health literate, I think those could be factors. So I'm just wondering if you considered that when you were doing your study. So let me just stop there. Thank you.
Thank you so much for the brilliant presentation. Mine is like a comment. I have some comments and also question. The very first thing is about the leadership, just as you said. Leadership are interested in finance outcome, the financial outcome. But I can say categorically that if we take quality improvements to be a business for us as healthcare provider, we will make the money. Why? When there is value for something, people will pay. And that was why during your research, doctor, during your research, cost came last. Why? Because people will pay when they see the value. So it's a clarion call for every one of us here seated that quality improvements, in fact, should come first. Why? Because a patient or a client or a guest will see quality as don't harm me, heal me, and be nice to me. Those are the 3 things that our clients, our patients are looking out for. And those 3 things, if we can undo it properly, in fact, healthcare system will be a place of excellence. Because I kept on imagining, there was a day we were having sessions down over there in Lagos, and I said, these people are putting food on our table. If you see it that way, then we'll have a different perspective about our clients. If you wake up as an individual, a healthcare professional, a professor or a doctor or a pharmacist or a nurse, and you get to the facility one day and there is no single patient, won't we be afraid? We will. Why? Because that means our job is at stake. We don't have anything. And that's why patient experience is key. Patient can be satisfied, but might not have a good experience. Why? I give an example. For satisfaction, patient is just saying, okay, I'm going to that healthcare facility to have my baby. Once that baby is delivered, the patient is satisfied. But how? What are the things that came up during the course of delivery? Those are the experiences. And if you take patient experience to be a very key thing in our healthcare system, the patient will be loyal to us. And when they are loyal to us, they are the ones that will advertise us there. We need not to place adverts everywhere. So patient experience is key and is a way to go. Then what are our wins in Nigeria? Because we are doing patient satisfaction survey. Initially, we're doing it on a quarterly basis, and later we changed to twice in a year. And what was our findings and our experience? At the very beginning, we just came up with questions, presumed questions, from our own perspective as healthcare provider. Alas, our patients were not really forthcoming. They weren't answering it. They would just leave most of the questions unanswered, unattended to. So later we engaged them. When we engaged them, based on their preference, some of their input was, one, communication, just as it's reflected on your slide. Communication was key. They were like, you people don't communicate with us. The staff don't communicate with us. Before we even say what is going on in our system, the doctors has finished writing prescription. And when we get to the nurse will not tell us the kind of medication. So communication was key, blah, blah. So they gave us the list. So we came up with another thing. And it worked for us. Then at the third stage, we came up with a structured questionnaire with back-end analysis, barcode. Because not every one of us could analyze. So the leadership got an analyst that developed a template. As we're inputting those the responses, it will be analyzing it at the back end. And we recorded quite a lot of, interventions through their feedback. But where we are presently now in Lagos State is that most of our hospitals are now using QR code. Instead of the paper base that you distribute to the patient, we have QR codes on our wards everywhere, notice boards. So for comments, we just write for comments, complaints, or commendation. So by the time they snap the QR code, they will answer the questions and we'll analyze it. And it has really worked for us. I wouldn't know if we want to imbibe this in this gathering. Thank you.
Thank you. Thank you so much for that input. I think we take one from the back. There's a hand at the back. Oh, yeah, go ahead.
May I?
Go
Okay.
ahead.
Okay, good morning, everyone. Thank you very much, Benta and Dr.Jackline, for those interesting and informative presentations. Mine is just one. I wanted to find out from Benta if you have some tips on how we can improve response rates from our patients or clients or guests. What I mean is when you get like 100 clients going through your facility, you'd want, the best is to get feedback from each and every one of them. But from where I work, we've had some challenges in trying to get feedback from clients. So can you give us some tips on how we can improve our response rate? Thank you.
Thank you. For gender balance, let us take the question at the back, please. And then we answer those ones.
Very happy to balance the gender. Well, thank you very much for the wonderful morning presentation from very eloquent and informative presenters. I have to admit that you have shared with us a very comprehensive information, and probably we have a lot to takeaways from your presentations. My two concerns as follows. In the view of the patient that we see in our hospitals, the number that comes in a day, and probably in a clinic, and in view also of the number of staff, our hospitals, we have few doctors, we have few nurses. And you find out that some of the things are like impossible, or you think it's not necessary, you do them. For example, introducing your name to the patient. You want to introduce yourself to 40 patients. The fatigue that comes with introducing yourself really changes the focus from the clinical point of view. How do you survive in those particular environments? What will be your take? What will be your advice from the clinical point of view? Our patient, when you want to engage them, you find that they lose power, or they don't have power to comprehend the information we are sharing, number one. Number two, to really engage in a meaningful discussion with you. You'll find that I want to do surgery to you. This is hemorrhoids. There is open method, there is PEX method, there is injection method, and you want them to choose. You find that they are not aware, they don't have, they can't really give you an option. So for them to make choice, they depend on you as a parent, paternalistic approach. You know it better what your son or your daughter has to go through. Please decide for me. Will I be doing right when I continue doing so? Because I find like wasting too much time giving them an opportunity to propose some of the treatment options, yet they can't. If I tried for three and I have a list of four or 10 patients coming in the row, and then I say, okay, the other 10 I won't do anything, I'll just propose. You paracetamol, you ibuprofen, you tramadol, based on what I think. Will I be doing right? The second comment is about the tools that we use to measure patient centeredness, involvement, engagement, or those things. I want to assure you that this is a very new concept. We might be trying to do some bits of the entire presentation has taught us, but the tools we are talking about, are they Afrocentric, so to speak? Like here in Kenya, you speak Swahili. Are the tools that you are using here translated into Swahili? And are we doing tafsiri sisisi? This is a layman translation, or we are getting the entire translation from not losing the context of the tool? And will it be giving us the same results? Does it allow customization to capture some of the cultural backgrounds? Like in my clinic, they know I'm the only surgeon. There's no need of wasting too much time again to introduce yourself. They know when they're getting inside, they'll be meeting Mugisha. Is the same yesterday, is the same today, is the same tomorrow until proven otherwise. Where can we find a common ground to at least think of what is happening in our context, and really come with a proposed either I call it Afrocentric tool for patient centeredness, in view of integrating and realignment. How far have we gone, and how far should we be going again to engage? In our context in Africa, when you have a very good buy-in from the political arena, things moves very much. WHO African region, does it support what we are talking about? African Union, the Center for Disease Control, does it integrate all these things and try to move as agenda from the top political officers of the continent, and then trickle down effect to the Ministry of Health? How do we hold our leaders accountable? Health delivery is purely scientific, but it depends too much to the political will. If the politicians say tomorrow is a free health, it is a free health. If they say no, no. How best can we get them engaged in terms of trickling down the effect of patient-centeredness in the quality of care? Thank you. That's my submission.
Thank you so much.
Okay. Okay, my name is Lucy.
That should be the last one.
My name is Lucy Simoto from Kenyatta National Hospital. My name is Lucy Simoto from Kenyatta National Hospital. Thank you so much, Benta, for the wonderful presentation. I want to brag that as Kenyatta National Hospital, we have structures in place for patient-centered care, and we do patient experiences, we document patient journey, we also do patient-reported outcome measures. So I think we are in a better place. So my question is, number one, what are some of the initiatives that you are doing in Nairobi Hospital in terms of engaging staff so that we can copy the same? Some of the, yes, we can still. The practical one that we can copy in a public sector. Then secondly, we do have frameworks, we have policies in place in terms of patient-centeredness, but now, how can we implement it in a more practical way so that our patients, or even, so that we can feel the change? Thank you.
Thank you so much. Any burning one here in front, please, here in front, the last one. Yeah.
Let us help. Let's have, if you're among the first one, then somebody here. Then we go for tea after we get the response.
Okay, thank you very much, Dr. Orindi, for that presentation. I think my question is about equity. So it appears poor quality of care is a problem of poor people. For example, less educated women, women from low socioeconomic status. So now, from a health systems perspective, how can we entrench equity in quality for vulnerable populations? Yeah, thank you.
Thank you so much. I think we'll answer those ones first, and allow me to distribute them. I think we'll start with Benta. Benta will respond to a question on the response rate, improving the response rate from our clients who pass through our facilities. I think the other one she will respond to is how do we move away from paternalistic care, where the doctor is the boss, and giving power to the patient so that the doctor does not feel tired in introducing themselves and using these tools to measure the experience. And I think the other one, Benta, you can also talk about engaging the staff so that the staff also feel engaged. And then the question by Rusi on then how do we then benefit from the patient experience?
Okay, thank you, Paul. These are many questions. I'm not sure we will exhaust them, but I will certainly try and get us through as many of these as possible. In the matter of improving responsiveness, I guess this is not anything that you must do specifically, but when a patient comes into your facility and you have displayed the fact, for example, that we value your feedback, using public information or using, in areas that they can see, the fact that you're looking to get their feedback would be one. Secondly, you want to be able to have a response or a questionnaire or a way of responding that is easy to use. If your questionnaire is long, we will get tired, we will not fill it. You want to have access. The idea of the QR code has by the way, is a great one. We have, the place I worked for has QR codes displayed in many sections so that if you want to give feedback about any station that you've been at, you can be able to do a QR code right there on your phone and give feedback. A lot of patients now have their phones, and that becomes a very easy way to do it. Alternatively, rounding is a very great approach to getting feedback. Rounding would be both administrative rounding, where you have your senior managers actually visiting patients and asking them what their stay has been like. Is a deliberate round that is done by not the clinical staff, but the other staff that do not give care. And if you tell the patient, for example, introduce yourself, my name is Benta, I am the administrator on duty today, and I just want to know how your day has been, they will give you feedback. Some of this feedback does not have to be written. It can be spoken, you can have a conversation with the patient, they can send you back feedback on social media, so having your website accessible, having your email accessible, having even WhatsApps accessible to patients, numbers that they can send to, and identifying individuals to whom those ones can be sent becomes a great way to get your feedback. And so, in addition to that, of course, your nursing rounds as well. We have not seen doctors doing rounds other than clinical rounds, but you might want to have them talk to patients as well. But the nursing round is super. And not necessarily the primary nurse. The primary nurse will talk with the patient and pick what they can, but the administrator who looks after the general hospital function will also be able to elicit some of those things that you can use as feedback. So you can get feedback in multiple ways. As for the doctor, the boss at the back there, I know that for the longest time, what the doctor says is what goes, but we are beginning to teach our patients that they have a voice, that they must be able to tell the doctor that this is the way they feel about their care. The doctor must come to a place where they have time for the patient. You shouldn't come to the place of visiting the patient and you're there for 2 minutes, the doctor's in the house, you're there for 2 minutes and then you're gone. Sometimes you have written 1 or 2 instructions, sometimes you've said nothing, you've said continue management on your documents, and you have gone. And you expect that the nurse will be able to communicate what you want done to the patient. You must have time for your patient. You must, first of all, as I mentioned about communication, you must meet your primary nurse, have a conversation with the nurse about the patient. And this then would be where we use a standardized method of communication that we now call ISBA, that tells introduce yourself, you tell the doctor the situation of the patient, and you give that doctor the background of the patient, meaning between the last time they saw the patient and today that they have come. You give the doctor your assessment of the patient, and that would be A, and then you recommend what you think should be done. Nurses must be empowered to that extent. This is what I think we should do for the patient today, and you have a meaningful conversation with your patient. So when you go to the room, your doctor is armed with information, and so they must sit and have a conversation with the patient. So the doctor can no longer be the boss. They must have that discussion, and by the time you get to my patient, the patient is well aware because the nurse has had a meaningful conversation with the patient. You don't go to the room and say, I've come to do your blood pressure. You go to the room and ask them, how was your night? And if it is a foreign patient, have you been in this region before? Where is your home like? What is your family like? As you do their vitals, engage the patient, and in that instant, give them information so that by the time the doctor comes, you can remind them. This is what you want to ask your doctor. Write them down somewhere so that you don't forget. In certain places, you even give them paper and pen or a whiteboard or something that they can write things that they will want to question the doctor about when he comes. So the doctor has no choice but to sit and have this conversation. So you're no longer boss. You have to be your patient's partner in their management, in their healthcare journey. I will do the engagement of staff engagement. as I said, if you don't have a good staff that is looked after well, remember the chart we did at the back there. The patient is in the middle, then the staff follow, then the community follows. Your staff engagement is vital. I only give what I have as a staff of the hospital. So making sure administratively that you look after the welfare of your staff. Staff are looking for training and development. They want to develop themselves. They want to know that my employer knows that I need to progress in my journey of my career pathway. You must have this conversation, how you will support me in my journey. You must also look at how you recognize my performance, how you remunerate me if you can. If you're talking about tokens, it doesn't have always to be monetary, but treating your staff as valuable gives them the impetus to want to do for the patient what they came to do in the morning or in the afternoon or at night for that matter. So treat your staff right. Engage them in everything you wish to do. If you're going to do the patient experience, get their feedback, have them understand it, so that because they are the drivers of these things. Have them understand it, have them own it, so that you're able to achieve what you're looking for. And lastly, in terms of how we get patient experience going, we discussed some of the foundational requirements, about 8 of them, which is on the presentation. But there are other strategic lenses that one wants to address when they're looking to have a patient experience implementation. And this perhaps would be the 5th, I think I shared the 5th of our takeaways. You must, if you want to start the journey, look at, of course, you've looked at quality and clinical excellence, which Kenyatta has done very well, and I've been a beneficiary of that program. Patient and family community engagement, and we've talked about engaging the community. We said they tell your stories. Whether you like it or not, they'll talk about you. Family engagement, they will tell you what you need to put in place for your organization so that you become their choice. We said they have choices, and choices have consequences. As we were told at the back there, the choice of being patient experience centric is what will improve the bottom line of your organization. Because financially, if I have a good experience, I will not only come back, but I will tell my friends and family to come to this place where the experience is good, and that naturally translates to a better bottom line. Then look at innovation. I know NH is doing a lot of innovation and technology in terms of engaging your patients through technological advancements. You want to look at the environment and hospitality. We have stopped talking about the hospital as a hospital. We are comparing the hospital with hotels. So what I find in the comfort of a hotel room, I should be able to find in the comfort of a hospital so that I can be able to want to come back. My comfort is really, really important. Policy and measurements we have talked about. Staff engagement we have discussed. Look at infrastructure, but governance is vital. Your governance must be right so that you can get this right. And then your culture and the leadership that runs the institution must also be addressed as a very strategic lens in implementation of patient experience, a model of care. Thank you.
Thank you so much, Benta. Dr. Jackline, I think you respond whether religious belief may have affected the study. The other one is to do with health literacy for the women in the rural areas and also in the urban areas. How are the literacy levels? And I think the other question is, in terms of all these tools, customizable are they so that we can borrow them in a simpler manner that will resonate with our cultures and our many ethnic groups that we have around in Africa? The last question will be, you will talk about equity. In terms of patient experience, do you think equity plays a part?
Thank you, Paul. So the first question on how it would affect Muslims from my Nigerian sisters, I think this is a sampling question. When you're doing quantitative research, you need to have a representative sample, and we don't exclude anyone. And in our community engagement, Christianity in Kenya is widely accepted, and the Catholic Church accepts anyone. So all the programs that are run at the Holy Cross congregation in Dandora, we opened it to everyone, and we did have community engagement sessions outside of the church. So anyone who was Muslim, who was afraid to come into the Catholic space, we would hire halls and have the community engagement in advance of the research, so that we don't have bias that this is a Catholic Church program. It was for everyone, and there was awareness around that. Secondly, on health literacy affecting patient satisfaction, I agree with that. What we did was we collected data on education as a proxy indicator. So we used education and controlled for the level of education of the people whom we interviewed, and this was able to let us know their views regarding the level of education, or whether you were not literate. So we had categories on how educated you were and whether you had an education or not. And when we ran the analysis, we could control for the effects of literacy, but not health literacy specifically in the way that you describe it, right? People's knowledge around diseases or well-being, but education is a proxy indicator that we use for that. And in terms of awareness of rights, I think that's a very tricky question. It can be political, and it can be subject to the subjective norms in the area. So people's behavior is sanctioned by who they're interacting with. So there are certain power dynamics in some of these peri-urban settings where the healthcare workers are middle-class people who come from the main part of Nairobi into Dandora. And so there's a power dynamic there, especially regarding people of lower socioeconomic background. So even if you're aware of your rights, sometimes it's very difficult to take on a conversation with somebody from a higher socioeconomic class than yourself. So it's something that will change with time, but also needs the hospital to take that into account. On the question of the tools, I think the tools are Afrocentric. So one, when we talked about the validation of the tools, I think the paper by Afulani describes exactly how the tool was validated. There were pilots, there was translation, including our papers talk about translation, and specifically even to the context. I have one of my former enumerators here, Wamboi, can speak to how we would even speak in the way people talk in Dandora. When we do the pilot, we'd get feedback on the best way to ask the questions. So we train our enumerators on speaking about things. For example, when we talked about bribes, we'd use in Kenya, they call it kitu kidogo. So everyone in Kenya understands when you say kitu kidogo, something small. So we'd take that into account so that it gives the real meaning of what we're trying to ask. So that's the customization that we did. Then on the question of equity, I think this is feedback to the quality improvement community. There are certain populations that you need to focus on, and I've seen this happen in some of the facilities in Dandora. In some of the facilities, they've created desks for youth-friendly services, and they provide it separately. And this is in response to some of the feedback around less educated women whose children don't have diapers. There's a lot of class issues going on in Kenya as a society when you show up at the hospital and your experience is determined by your background. So I think the hospital departments need to take that as feedback and provide the service according to, by taking special consideration on these different populations. And also generally, gender equality is an issue in this country. We still have not reached the point where men and women are being treated equally in different settings, including in our politics. So I think that's for us to get more gender awareness and gender equity issues that may affect different populations. Then lastly, I think there was a concern about the ratio, the number of people that are being served and the staff. If you're seeing 40 patients, I think working in a dynamic health system in Kenya, we're now seeing different changes. And as Paul mentioned in my profile, we're doing work with the primary healthcare networks, and those from the ministry are aware of that. And this is a very flexible model where people are now organized. So it's a hub and spoke model where you have a level 4 hospital working together with level 1 and 2 hospitals and the community health units. And people are adapting care to the context. So we're having innovations such as in-reaches. Instead of doing outreaches, people have a roving healthcare worker who's moving in this primary healthcare network. So healthcare workers are moving from level 4 to level 1 and 2. In a primary healthcare approach. So I think the issue of the shortage of healthcare workers cannot be the only issue that plagues us as a continent. We need to find dynamic, innovative ways. There's telemedicine. People are trying different things. People have gotten the blessings of the ministry that this is your healthcare, own it, do it in the way that works best for you in the area that you are. And one thing that came up again in training the healthcare workers in primary healthcare networks was partnerships and communications. How do you form partnerships with people outside the health sector? And 2, how do you communicate with people whose who influence the healthcare of the people whose health you're taking care of? You know, if there are certain behaviors, certain cultures that are interacting with that, there needs to be more communication within the primary healthcare approach. So I think it's a different kind of thinking and a health systems approach that is moving us from curative approaches only, but also taking into account primary healthcare approaches that are different and meet the challenges that we are facing as a continent. I hope I've answered the questions, Paul.
Oh, yes,
Thank
you so much. And thank you so much, audience. I think I want to give them 30 seconds so that they can give us a take-home. And I'd also ask Benta. I know our doctors struggle a lot in terms of using language that is understandable to their patient without using the medical jargons. Maybe you can also comment on that as we close.
Well, I believe that as clinicians, when you admit your patients and when you're coming round to see your patients, it is very important that they understand why they're there, what they're being treated for. What I have seen some very effective clinicians do is when they come and have that sit-in with their patient, they're actually armed with a piece of paper and a pen, and they have a conversation, draw even pictorials to demonstrate what they want to do for the surgeon, explain in as lay a way as possible to enable the patient to understand, considering that some of our patients are not that literate. But the ability for you to understand your patient extremely well, and you're making them comfortable to the fact that they can ask questions, makes it very easy to be able to communicate with your patient so that they understand what their care is about. When we talked about the tool, the patient experience tool, when one finishes having this conversation with the patient, when you're educating your patient, it is important that the patient themselves explain that they've understood. The amount of information that you have given them, even if you think it is enough, it is only the patient who can then say, actually, you have given me enough information for me to be able to understand my care. But importantly, you can invite the next of kin into that conversation. You can invite the children, the care partner, or whoever else will be with the patient towards the end of the stay. And that person must also confirm that what you have explained in as lay a way as possible is understandable to them. Because when you're not there, they must still go home and be able to look after themselves based on the explanation you have given, so that transition of care from the hospital, especially when they are going home at discharge, is as clear as possible to the patient. They will give you feedback that the information you've given is adequate. Thank you.
Thank you, Paul. I think for me, coming from the academy, the big takeaway that I would give this community of quality improvement leaders is we need to translate research. There's a lot embedded in research that can help us think differently about the challenges that frontline workers are facing, and the challenge is how do we translate research into good quality care, and how do we understand the different metrics that are interacting. Sometimes it goes beyond the traditional metrics, and we need to take approaches that go further upstream. What is the problem? Also, one, getting the voices of women, patients, and families, but two, also understanding how to better organize healthcare. Healthcare workers need to also have a paradigm shift with the changing patient. I've had people complain about Dr. Google. People can get information on ChatGPT, so people need to say that, yes, you got that, but as Benta is saying, how can we refine that better, and how can we make it work for your health? Then secondly, I think the quality of research has to be high. It has to be contextual. It has to have local principal investigators. And we have to invest in the importance of research. Some of these studies take a year, 2 years to just get comfortable for people to tell you they were mistreated. It was really difficult. They said, no, who are you? If we tell you, you're not going to tell the, that confidence, and having community organizers and using the community structures and culture that says, no, this is for betterment. We're looking to improve the quality of service that you get. We're not out to victimize anyone, and this was so important in Dr. Nema's presentation, those incidents reports. I think if we take some of these community approaches, also with the healthcare workers, it's about engagement. How much are we engaging, and how much are we doing research that has a component that engages the community without assuming that the community views healthcare workers like this, the community thinks this. Did you talk to them? Did you engage with them? Did you know their interests? And then finally, that will now lead to research just feeding into practice, and people having a culture of using data and evidence to make the quality improvements that are currently being made. Thank you.
Thank you so much, team. We want to end it there. So kindly browse our two presenters. I want to hand it over back to Ruth Pearl. We'll take our break.